You know what you're listening to, right? 3, 2, 1.
Uzima Health and Wellness.
What the doctor say?
Hi, Dr. Erich Conrad. Thank you so much for joining me today. I'm your host, Dr. Kendra Outler of What the Doctor Say podcast. First of all, you are board certified psychiatrist and you are the director of the Psychosomatic Center for the LSU Health Science Center Hospital.
Sort of, yeah. So I'm the service line director for behavioral health at University Medical Center in New Orleans. So it's kind of like the psychiatric medical director for the services that are provided here.
All of the services that are provided at the center?
Yes, at University Medical Center.
Now, I noticed that you are from Louisiana. You definitely went to LSU undergrad, medical school, and residency.
Yes, high school years on, been in Louisiana, and then, I've been in the LSU system ever since undergraduate.
So you're bathed in purple and gold, as they say, or is that purple and yellow? What is it, purple and gold?
Purple and gold.
Don't get me in trouble, because we know how much you LSU people love LSU. So, all right, now, how did you like undergrad at LSU? It's a great state university.
Oh yeah, it was a terrific experience. I was actually an English major in undergraduate, and then did the prereqs for medical school at the same time. So it was a terrific experience.
I love English. I was a mathematics major, and I think this is an important point here for all of the young people listening to Two Doctors Talk, and that is that you're not a biology major, and how cool is that? Because you bring all this other information to medical school with you. What made you pick English as a major?
I just really enjoyed the classes. I didn't know that you could get into medical school and not be like a biology major. And so then once I found that out, it was like, wow, I can just, take these English classes, and they were a lot of fun and really enjoyed them. And then just took the required courses that you have to take to get into medical school. So then it was unexpected, because I never really liked English either when I was little, or reading it at all. And then ended up being an English major. Yeah.
Did a teacher or professor all of a sudden change your feeling or love about English?
It was actually a Shakespeare class that I took as a freshman. And it was this really creative way of looking at things, and it was just a lot of fun.
Let me ask you this. What's your favorite author, or is it Shakespeare? Or are you classical?
I guess my favorite author would be sort of the classic Russian authors like Tolstoy, Dostoevsky, things along those lines.
Well, like of Crime and Punishment. That's the only Russian book I remember reading, of Crime and Punishment. We had to read it in high school, but after that, I didn't study much more literature. So I went into the mathematics, which is another language, right? That's what we say. And even medicine is another language. And I find it interesting that you're a psychiatrist now, because all of this seems to have now, propelled you into this leadership role in psychiatry. Because one thing you do as a psychiatrist is listen to people, and then you have to write a narrative about them. Am I correct?
Yeah, definitely. I think being able to relate to people in a different manner than, being, too stiff or, just thinking about the biologic aspect of a person's life is important if you're going to go into psychiatry.
What else do you love besides English and psychiatry? Tell me about yourself.
Well, I like going out to eat. Being in New Orleans is a ideal spot for that. Terrific restaurants. And I guess, just following the Saints and the Pelicans.
Are you a family man?
Yeah, married and have 5 kids.
Wonderful. That's wonderful. We like to eat in the South. We like big families. We like big family gatherings. So I can tell you're a Southerner. Where are you originally from? Where are your parents from?
So my mom was from New Orleans and my dad was from the Midwest.
Okay. Because I tell people that, we describe New Orleans as the New York of the South. People can forget how varied that New Orleans is as a city in the South. And so, we have a large Vietnamese community there. You have a large South American community there, generations, of people who have come from other countries and made New Orleans the great place that it is. If you haven't spent time there, I think that all the places in the States, it's a great city to go visit. My neighbors are from Brazil, and they're taking a trip to New Orleans before they go back to Brazil. So I highly encouraged it. You have been in the New Orleans area. You've trained at LSU Health Science Center. You've done your residency there. So you probably have a really good perspective of like a timeline of, major events for the city. One thing I'm thinking of is just, maybe take me through some historical things, like maybe I'm dating myself, 80s, 90s, of things that have shaped the medical community in terms of a need.
Well, I guess the big turning point that I think is, was obvious was with Hurricane Katrina. When that happened and Charity Hospital was shut down, and then we had some interim hospital locations for the trauma center, and then the building of the new hospital at University Medical Center, which is now where we are now, has really, provided a lot of growth for the different departments, especially for psychiatry. So that's been, it was really starting over from scratch and then building up from there to the comprehensive services that we have now.
So the question is, we have a little bit about the charity healthcare system. Can you give me a little historical perspective? Because you trained at big charity, I presume.
Yeah. And so Charity Hospital, it's University Medical Center as its successor is the second oldest hospital in the country. And so the hospital, the original, big charity, was vital to the safety net, catchment hospital for the underinsured or uninsured, and also it's the level 1 trauma center. So all the serious injuries were brought there. It didn't matter if you had insurance or not. It was the place to go if you were seriously injured. And that legacy is still with us today with the University Medical Center, still acting as a safety net hospital. Doesn't matter as far as your insurance goes, and it's also the place for training for LSU and Tulane schools of medicine and their programs.
So the question I have is, Old Charity had how many psychiatric beds, and does the new University Medical Center of New Orleans have the same number of psychiatric beds?
I'd have to double check, but Charity had somewhere in the 90s as far as the number of beds, and the University Medical Center has 60 inpatient beds. But we also have more outpatient services. So there really wasn't an outpatient psychiatry clinic associated with Charity Hospital. It was the public mental health clinics that then served as the outpatient clinics. But now we have a new outpatient clinic or an outpatient center that has within it a general psychiatry clinic, an addiction psychiatry clinic, a general intensive outpatient program, and an addiction intensive outpatient program. And we also have integrated clinics. So speaking about gun violence with our trauma recovery clinic, it's psychology, psychiatry, social work that are embedded within the trauma surgery outpatient clinic. So if the surgeons notice someone that's having difficulty after a serious injury, we're right there in the clinic where they can sort of hand them off and say, hey, we got somebody you can talk to or that specializes in this, and then they'll introduce us to the patient. Also, it's easier for the patients, sort of like a one-stop shop where if they need to come in and get sutures taken out or whatever, it's also in the same location where they would come and see psychiatry or psychology.
You went on and explained the trauma clinic. What I want to ask you in terms of your historical perspective, you're seeing a reformulation of how you trained as a resident, and now in this leadership role, how you deliver psychiatry. So I guess tell me some of the benefits that you see by having this new framework of maybe not so many inpatient beds, but now have deployed smaller clinics to work with the community as the varied needs, are presented.
Yeah, so I think it's a different model of care where you have integrated, it's called collaborative care, where you can work within a clinic. So we have psychiatry in trauma surgery clinic. We also have psychiatry embedded in the OB clinic. It's like a perinatal psychiatry clinic. Also within the oldest model that's been around for quite a while is psychiatric and psychological care within the HIV clinic. And then presence in the oncology clinic, and GI clinic. So all these different locations also helps, I think, with access for patients. And then it also helps with, specialization. So if you have a group of people that do nothing but PTSD and depression following a physical injury, if you have a physical injury and then are dealing with depression and PTSD, you're going to see people that, know exactly what they're doing to help out. And I think your quality of care improves. It's the same thing as if you're shot and then you're brought to just a regular community hospital, your odds of survival is not as good as being brought to the level one trauma center. So you have people that specialize in that and do that, nothing but that over and over. The quality of the care is going to be much better.
Okay, so you're seeing an upward, you're seeing a more focused ability to treat patients more specifically, kind of like anesthesia, my specialty. I mean, we don't have to do general for every case. We can now tailor the anesthesia for the patient and the surgery and what we need to do. You have a background in psychosomatic psychiatry. Not even a background, you've written a number of papers and done a number of presentations. Before we get into the trauma clinic, tell me about that work and what's most passionate about that for you.
Well, that's the old name for what's now referred to as Consultation-Liaison psychiatry. That's the subspecialty of psychiatry that does the consults throughout the medicine and surgical floors in the hospital. And so we created a fellowship for that a number of years ago. And that's grown, and the fellowship has grown, and the faculty for that has grown. And I think that's been a lot of, the best part, I think, of being able to have a leadership role is developing, new programs like that. And so the CL fellowship, which has now been going on for over 10 years now, has really improved, I think, also the relationships between psychiatry and the rest of the hospital in general. So you have people that are, very responsive. Again, it's just more of a subspecialization. If you have a psychiatrist that's, feels very comfortable going into the ICU and dealing with patients that are, have tubes and all sorts of drips, going on. Whereas if you're not doing that every day, you're not particularly comfortable in that sort of situation. And then, your recommendations may not be as effective. So I think that's a really nice part of the continued growth of the subspecializations within the department.
So specifically, by having the ability to interface with internal medicine and the other teams like surgery, you are helping those teams decide if there's a psychiatric need or this is part of the patient's, disease sequela or trauma sequela. That's what I'm understanding from you?
Right. So we get consulted for all sorts of different reasons. It might be, if somebody is hallucinating or really agitated, is this because of the infection that they have and it's causing their brain to act that way? Or do they have an underlying, primary psychiatric diagnosis like schizophrenia or something? And so we help tease that out and then also help determine, what's going to be the best treatment plan going forward. So those kind of things is really common. Also get consulted for depression or PTSD in patients dealing with their illness in the hospital. Also get consulted to help with addiction in the hospital. Somebody, let's say they get admitted to the hospital because of an infection, because of IV, heroin use. Then they start going through withdrawal, and then they'll consult us to help manage the withdrawal or place them on a maintenance agonist therapy with some other agent.
I think just like, people ask me what cases are you enjoy or you are very interesting. I personally do like working with my psychiatrist. We tease each other. I'll say, oh, there's my favorite anesthesiologist. And he'll say, oh, there's my favorite psychiatrist, because he actually was an anesthesiologist in his country. And so when he came to the U.S., he retrained as a psychiatrist. So I enjoyed talking to him about the cases and understanding, more and more about ECT, electroconvulsion therapy. Has that evolved from this kind of very dark ages type of perspective? Educate us on electroconvulsive therapy.
Yeah, so that's come a long ways from what's depicted in horror films or old movies and stuff like that. So, one of the keys is the anesthesia providers being there and making sure that the patient is asleep, and then all their muscles are totally relaxed, and then the electricity is delivered, and it's not like somebody having a full body thrashing sort of seizure. It's just their brain having a seizure that's monitored, and then seizures last about a minute. And then the patient wakes up after about 5 minutes. So the whole procedure itself, is like 10, 15 minutes tops. And then the patients, come to, and then they're observed in the recovery room area. And then either go back to the inpatient unit or go back, outpatient, go home, and do whatever. Except drop, supposed to drop it.
So you do have an ECT therapy service, I'm sure, as a tertiary care center, and you're recommending which type of cases typically end up needing ECT therapy?
It's usually cases that are, refractory to medications and psychotherapy. Usually people have failed a number of different medications and different trials of different agents. And then ECT would then be indicated. And so it's usually patients also that are just, very severely ill to the point where, they're losing weight and they're not eating and not moving around. I guess the most dramatic cases are when people are catatonic. And that's basically not, moving or speaking at all. And then the ECT, we've had some really dramatic results where people come out of it, and it's like bringing somebody out of a coma, basically. And it's that's, you were saying, like, what's the sort of favorite cases? That I think the catatonic patients that we're able to help. And the nice thing is that ECT works like 90+% of the time in catatonics. It's like the more severely ill you are, the better the results are. And so the catatonic cases, it's often very dramatic, and families are really amazed. It's like bringing somebody back from the dead, basically.
It's pretty remarkable, even what we can do now with all of the therapies. And again, this is when cases are refractory to medications, and this is about a quality of life for the patient. So, speaking of, these cases that are very severe, trauma can actually make someone severely depressed, catatonic even. So, this concept of these acute trauma clinic, I find amazing. I mean, you all have been developing this clinic. Is it a new idea for a major medical center? So I'd like for you to kind of introduce us to this concept, please.
Yeah, so it was started over 5 years ago. We've got a Baptist Community Ministries grant to create this clinic. And so it's basically having psychiatry and psychology and social work embedded within the trauma surgery clinic, and then specializing in treating patients that have been injured and admitted as like a trauma activation, that and their families. And so if somebody's loved one is severely injured, it affects the entire family. And so we'll also see the family members of people that have had a serious injury. We have a proactive consultation built into all the trauma surgery patients. So on the trauma surgery admit orders, it's an automatic check box to consult trauma psychology. And so psychology goes around and screens all of the trauma surgery patients for depression, PTSD symptoms, substance abuse problems, and then the potential for violence themselves if they were a victim of violence. And then anything that comes up with any of the screeners, the patients are then treated appropriately there in the hospital while they're in the hospital, and then are referred to the outpatient trauma recovery clinic embedded in the trauma surgery clinic. You would think like, oh, well, yeah, that makes sense. People are coming in, they've just been shot, they've just been mangled in a car accident or whatever. Of course, they're going to have a psychologist or a psychiatrist see the patient. And it's like, well, that's actually not the case. It is now a requirement for level 1 trauma centers to do some sort of screening, but that's it. And it's often carried out by like the nurse on the floor. So having the expertise at the bedside immediately following some sort of accident like that, and then also being able to follow up in a specialized clinic embedded within the trauma surgery clinic is actually very rare. I'm only aware of a handful of other hospitals that have a similar setup. And then we also have outpatient support groups for the patients and their families, and also liaison, or we have a lot of back and forth with people in the community. So if somebody, they ended up being shot because they're living a lifestyle that involves substance abuse or things like that, and then to get out of it, what do you need? And it's like, well, I never graduated high school, I just need a job. And so it's okay, well, we have people that we partner with in the community that you can go get your GED or some sort of skill, and then get a job that doesn't involve substances or dangerous lifestyle.
Let me ask you this. So it sounds, in theory, like a smooth machine, but we know in medicine, there's no, utopia or perfect scenario, right? So as you're, carving out some of the challenges to this concept, which I think is absolutely wonderful and definitely much needed, especially in a level 1 trauma center, what are some of your challenges?
I think making sure that the patients are aware of the resources that are available. So it's, first of all, it's, catching everybody, and make sure that people know that, we're here and that the treatments are available, and that, that if they need something, all they have to do is basically ask. I think a lot of times there's barriers that come up. One could just be, stigma about, seeking help for any sort of like mental health. A lot of times it's transportation.
Yes.
People are, just don't know where to go or how to get to an appointment, those sort of things. And so those just kind of like basic, know where to go, know to ask for help, and don't be embarrassed or, ashamed. And then, just trying to make sure that somebody can actually get there.
I hate to interrupt. That's an important issue, the barriers. And so one of the things that was discussed by a recent a book I read about Hurricane Katrina and some of the aftermath and health disparities and racism in terms of the social determinants of health, where you live. We're uncovering more about systemic racism in terms of housing and also transportation and environmental challenges like how we destroy trees in certain areas. So transportation was one that I never explored as much, but of course we saw that with the devastation with Hurricane Katrina, where, people are like, why didn't they evacuate? Well, people didn't have transportation. So will the advent of telehealth help with a traumatized patient for you to be effective and to make sure that maybe, all of the people who go to the clinic who don't have phones are you employing some type of, partnership so that you can make sure that maybe you can employ telehealth appointments so that you don't have that challenge?
Yeah, so that's a good byproduct of the pandemic, was that everything's totally set up now within the clinics to provide telehealth visits. And so, and it's also helpful, let's say you have somebody who's been, I'm just thinking of a case in particular, is severely injured, now is in a wheelchair and, has a catheter for their bladder and all this sort of stuff. And so they're not the most active, people to get out and come to a clinic visit. And so, but that person's able to continue to be seen via telehealth because it was already all set up, and it was, it's difficult. Even the things that are sort of built in through like Medicaid transportation and things like that. Unfortunately, that's also rather unreliable. Nobody's on time, that sort of stuff. So it just makes it very difficult. And so the ability to do it on another platform, even if it's just, calling somebody on the phone, it can make it a lot easier as far as, eventually getting access.
Mm-hmm. I think, so that is one of the positive byproducts. I mean, we've rolled out telehealth medicine and it's not rolling back in. I've heard physicians say, it actually has helped me to visualize where my patient has to go back to when they left me. And I never really kind of factored that into my care plan. I can look at the ceiling, I can see how many people are in the room, I can see kind of what they're sitting on and what have you. So I think it has given us the good thing is a better perspective about who our patients really are and their conditions that they live in. So let's talk about what are the future expansion plans on this idea and actually what you have in place of the trauma clinic. I mean, what would be, like say the year rollout?
Well, it's something that we're looking into currently is how to, expand services. I think that, there's more patients that, we definitely see, and there's also different sets of patients. So currently the clinic is not really geared towards like domestic violence or things like that.
It's a huge
but
partner violence.
That's something that if we get the funding and support for it, where we could expand to not just physical trauma that's been admitted to the hospital, but any sort of violent victims of crime throughout the entire city. And so that would be more of a trauma recovery center, and there are models for that in other cities where that's the primary focus, and it's can be hospital based or not, but we would look at it hopefully being hospital based at the University Medical Center, and then have the expertise and the manpower between psychiatry and psychology and social workers, and to help case management, because once you're a victim of crime, let's say there's a tragedy associated with it, there's lots of things that you need somebody to explain, well, these are the legal routes that to take and things like that. So part of it would be built in sort of advocacy where you just have somebody that can help explain what's going on with all the complexities that are involved.
So right now, are you able to provide specific intimate partner violence, or you're saying that you need to build that into the whole trauma?
Yeah, that would be an area for us to expand, because right now that's not part of the routine referral pattern.
What about children, child abuse cases?
So our hospital is primarily for adults, and we do have children's hospital that specializes in child and adolescent cases. And so those probably be referred over there, where they have that sort of expertise.
Okay. So are you able to help children who've experienced trauma, which with this gun violence epidemic, I'm sure it's happening?
Yeah, so there's psychology and psychiatry that child and adolescent psychiatrists and psychologists that can specialize. And so that referral pattern is in place. That's not something that we do here at the hospital, but we know who does it.
So talk to me finally about the issue of gun violence in New Orleans. I mean, you've been there for many years. You've seen, I'm sure, some of the challenges of the city. Tell me, what's going on in the 504, as they say in the NO. How are you characterizing as a psychiatrist this version of gun violence?
Yeah, it definitely has increased since the pandemic. So looking just at the types of assaults that are brought to the hospital, the percent increase has happened, from like 2019 to 2020. Were not as many car accidents, and people weren't driving around and stuff, but there were an increase in the percentage of assaults, whether stabbings or gunshot wounds. Like as of this past few months, we've seen a percent increase in the trauma activations at the hospital, anywhere from 10 to 30% per month, depending upon the month.
Let me interrupt you, doctor. You wrote in this report I was reading about your center, it was said that there are about 300 to 400 trauma activations a month, and so you're saying you're up from that baseline?
Yes, and so now we're looking at as far as March of 2022, there were 448 trauma activations, and they're looking to possibly break 500 a month. So the amount of injuries that are occurring, it's definitely increased, and it seems to be a lot of gunshot wounds that might be driving the numbers.
So the question is, you said we're dating this since COVID, but if COVID hadn't happened, I guess my question is, would the line of cases still been steady? So we had a drop because we had a pandemic. The question is, can you say in the early 90s, this is really the same number, guys?
Well, I think early 90s, there were more people in New Orleans, and the population took a dive after Katrina.
Correct.
And then the numbers have slowly been going up ever since, as far as the population and also the trauma activations.
I got you. What role does drugs have on this? I mean, when I was there working, I did not appreciate that there was, this deregulation of pain clinics, and, they called it the Holy Trinity. They wanted someone's methadone, Lortabs, and, 90-day supplies. What are some of the compounding problems that you're having with this gun violence spike? Is it drugs alone?
I don't know. That's definitely, there's been an increase lately. It's a lot of methamphetamines and heroin seem to be the drugs of choice.
Really?
We see a lot of that in the emergency room. As far as that being a direct correlation with gun violence, I'm not sure if that can be proven or not. A lot of times, the gun violence may have nothing to do with drug use at all.
What about alcohol? I mean, we have to remember that alcohol is a drug, and people do drink it.
Yeah, some cases, I think that's also at play. But I think the majority of the patients that are involved, they come in as a gunshot wound activation. There's often not any sort of substance or alcohol.
So as you build this out over the next year, you need, of course, resources, which would be staffing and funding. That's going to be vital to moving this project forward, let's say for a 5-year plan. And what other community partners, that you have, so that as you build, you have this, I guess, a coalition of community partners. Would you like to acknowledge them as growing with the acute trauma clinic?
Yeah, we have a lot of people that we've been partnering with over the years, and then also that are helping us try to pursue grant funding that will hopefully bring this all together in a much larger scale.
You will make sure we acknowledge some of those on the broadcast. So who are we talking about? And I hope no one, if you leave somebody out there, understand that you meant well.
Yeah, because you put me on the spot here. I should have like a list of names that I wouldn't want to just shoot from the hip.
Okay. Yeah. All right. Well, we want to make sure that we know that this is not only a university health science center effort, that what you do can't be done without community partners, and it can't be done, without the support of course, funding. We need to make sure that good talent knows that, New Orleans has a very forward-thinking model for psychiatric care. I think that's important for anybody, to know about New Orleans. You have a large catchment area. You border Baton Rouge. Does their big baby charity still open in Baton Rouge? And you have Our Lady of the Lakes?
Yeah, the Earl K. Long Hospital.
Earl K. Long, that's what it was called. Baby charity.
That closed. And so those training programs that were over there were then absorbed into Our Lady of the Lake. Okay,
so then are you the referral area all the way down to Baton Rouge and up to how far? What is your catchment area?
Well, I guess it depends on, what the illness is. So for the ECT program, we have people that come all the way from Mississippi to Lafayette.
Oh, wow.
Yeah.
And so, and people need to understand that it's not just the city of New Orleans. You have your duty is to take care of people around the state and if you're the nearest trauma or center, they will be flown to you, right?
Yeah. So it's really the region. It's also, we have a trauma surgery, and we have a burn unit. Mm-hmm. And so a lot of the burn patients are brought in from all over the region because of the specialized care that they can receive here. And all the burn patients also, it's similar to the trauma surgery patients. They're all screened by a psychologist and then will have access to seeing psychiatry and psychology in the outpatient setting also.
Mm-hmm. So the question I have for you last, what if someone were to visit New Orleans, what dish would you tell them to try?
Just go to any good restaurant.
Not hard to find.
See what they have. I wouldn't narrow it down to just one dish.
Yeah, it's not hard to find. Well, I always enjoy beignets. I always have to have that. And I always get a seafood fried platter. So that's the one time that I allow myself to indulge in a whole bunch of seafood at one time. But I do wish, in all seriousness, I applaud the city of New Orleans and the work that you and Dr. Rajo and Dr. Bailey are doing to push forward this concept of the acute trauma clinic, and hopefully will be an acute trauma center. I have not heard of other areas that are around you, at least Jackson, Mississippi or Memphis, doing this. So I think that for the region, it's definitely going to be something that's definitely needed. You have any kind of encouraging words about what you're doing that you want to share?
Well, I think it's, high likelihood that, with enough effort and with all of our community partners, that hopefully we'll be able to pull this off and create an expansion of the clinic into an actual center. And I think that administration in the hospital is also in favor of it. Mm-hmm. And so I think it's been a lot of work to get to this point, and hopefully it'll come to fruition.
Do you have a magic number that you need for the funding?
Well, that's actually part of the process right now, is to solidify the budget. And so that's something we're working on currently.
Okay. All right. Well, I'll check back in with you all, because again, as we see this gun violence surge, we have to look for different initiatives around the U.S. and see which ones are working. And hopefully we'll have some solid answers as we survey and get ourselves out of this, I don't want to say pickle is just not the right word, but you know what I mean, this predicament in terms of gun violence and community violence as you characterize it. So let me let you go. I know you're very busy, and I thank you for your time.
Thank you very much.
All right, we'll talk soon.
What the doctor say?